Awesome. I think we are having people come on into the room now. Welcome, welcome. So glad you're here. Oh, I just sounded like John Oliver. Do you guys watch John Oliver? He's like, welcome, welcome, welcome at the beginning. That's what it reminded me of. Happy Wednesday. Wonderful to have you joining us today. We're excited about this discussion. My name is Rachel McCrickard. I'm the CEO and founder of Motivo, which is a online virtual clinical supervision platform for therapist licensure. We've been partnering with our amazing friends at Anthem to host these racial equity series. I think this is our sixth one now. We've covered so many important topics on topics around racial equity and social justice. And this is another one around exploring implicit bias in healthcare for marginalized communities. We have a lot of the same people that we usually do leading us in these panel discussions. I always get so much from them. So thank you so much for being here. I'll pass it over to my friend Meryl to say a few words about Anthem, and then we'll dive in.
Great. Thank you. Thank you, Rachel. Thank you, everyone, for being here. We do get really excited, as you can tell. But yes, this is our sixth one. So, and we're going to keep them going. So good afternoon. Welcome. My name is Meryl Friedman. I do lead the inclusive policy and advocacy here at Anthem. I'm a white appearing woman with short, curly, all salt, no real pepper hair, wearing a black V-neck shirt, and my pronouns are she, her, hers. We really, and Rachel really said this already, we're so thrilled that you've chosen to join us for the discussion today. I've said this over and over throughout the development of the series. We learn so much from listening, and the questions that you all submit early and ask through the chat, right? We continue to learn from those as well. But it's so important that we continue to come together to have deeper conversations about racial equity and racial inequities. And today to dig deeper into exploring implicit bias in healthcare for historically marginalized communities. So we do need to be having these discussions. We need to continue to learn. We need to continue to share, and we need to continue to do it together. So thank you for putting your questions in with registration, but please use the chat feature, ask questions, share thoughts, share resources, books, podcasts, anything that you may be interested in sharing that others can really learn from as well. It's truly interactive that way. And then lastly, if you can please just stay on at the end to fill out the online survey about the forum. So your feedback is important. We use it to inform the topics, right, and build out the content for the next forums in the series. So please tell us what else you want to learn about after this. My thank yous again for being here today and for continuing to advance equity across our country. Thank you for joining us. I'm going to turn it over to my friend and colleague, Dr. Demetria Malloy, who's going to be moderating today's discussion.
Hello there, everyone. So glad to be with you again. For those of you who are here for the first time for one of these webinars, and for those of you who are soldiering in this with us over time and committed to constant improvement, we welcome you all today. I am Dr. Demetria Malloy. I'm the Regional Vice President and Medical Directors of our Anthem National Accounts team, an internist, and been with Anthem about 6 years or so, committed to health equity. My pronouns are she, her, and hers. We have wonderful panelists with you today to talk more about our topic, and and encouraging people to define themselves and use their own voice. I'm certainly going to give them space to speak more about themselves and introduce themselves to you more formally, but I'll say a quick blurb about them. We have a guest, Harry Dixon, a licensed professional clinical counselor and licensed mental health counselor, and owner of Rainbow Connection Counseling Collective. And a crowd favorite of ours, Dr. Carla Smith, who's a licensed therapist and diversity, equity, inclusion coach, founder at Haven Therapy of Atlanta and Brownstone Consulting. Thank you guys both for joining us today on this important topic. We'll just jump right in. And usually we often will start a little bit with framing, with context, making sure people are understanding the language that we'll be using and some of the further discussion we're going to go into. So I'd like to open up room for that and start with you, Harry. I'd like you to say a little bit more about yourself and introducing yourself and your background and what led you to the panel today. And then really, what are your working definitions definitions, context, and some of your language choices for implicit bias? And how have you seen some of that manifest in your practice in healthcare overall?
Awesome. Thank you, Dr. Demetria. Welcome, everyone. I am so happy to be here talking about implicit bias as well as structural forms of racism within the field. Is something that I'm really passionate about. It is the heart and soul of the practice that I lead, and it is something that I encourage all of my clinicians as well as other clinicians in the field to actively challenge and talk about with clients, so that we can start change processes. So backtracking a little bit, my pronouns are he, him. I am a gay, polyamorous, Korean American male. All of those identities inform how I approach therapy and how I deliver therapy to my clients, as well as how I supervise my supervisees. And I am totally blanking on the question. It was
no, you started with some of the definitions of implicit bias, how it's shown up for you in your identity, and then how you've seen it sort of manifest in your practice and overall.
Yeah, absolutely. So how it manifested most concretely in my practice was very early on, and continues to be, this recognition that grad school really only covered the very tippy surface of implicit bias and racism as it exists within the mental health field. I'm aware that that experience might be unique, but from what I'm learning from my supervisees is that that is something that is all too common within our education. And so how this might look like is that there's an absence of conversation around how to apply certain therapies or theories to specific populations in a much more specific, less research-oriented way. So we're looking more at, instead of looking at evidence-based research practices, which may look at, or rather the samples are created by, and I just came across this acronym and I love it. A lot of the research in psychology is done on weird participants, and that's white, educated, industrial, rich, and democratic participants. And so they're not very applicable to a wider population, specifically those within the BIPOC and queer communities. That is another language point, as we're talking about it, is that when I'm talking about the LGBTQIA+ community, I tend to use the umbrella word queer. I understand that for some in the community, that is a very loaded word. And so I will do my best to interchange between the acronym and queer. I will also probably throw in there something like GSRD, which stands for gender, sexuality, or sexual orientation, and relationship diverse, to also incorporate the community as well. It can get confusing, so I encourage all of our attendees to use the chat to ask me to clarify or backtrack. I guess that's another implicit bias that shows up in practice, is that I notice, especially with the younger clients, that they're very in the know about these types of acronyms and identities. And so when my practice was much more focused around teenagers, I was literally learning a different identity or a different word, I think every week. And so that's just very briefly about my experiences. And I welcome any questions that y'all have.
Yes, we're certainly going to peel back some of the layers on that. I'm going to pass it to Dr. Carla for the same kind of question. So certainly a little bit more on your intro and your background and what led you to the panel today, and then how you've seen the language used around implicit bias and how you've seen it manifest in your practice and overall.
Yeah, thanks so much, Dr. Malloy. It's so great to be with you and Harry today. As Dr. Malloy said, I am Carla Smith. I am a marriage and family therapist, a licensed marriage and family therapist as well. as a licensed clinical social worker in private practice in Atlanta. I also do some work around diversity, equity, and inclusion for healthcare providers. So coaching for people who are really trying to explore and uncover harmful biases that impact the people that they serve. I am also newly the director of continuing education at Motivo. So really excited to do work around access and equity in not only our training for mental health providers, but also largely working around healthcare equity. That's very important not only to my work, but also to the clients that I serve. Most of my clients are somehow marginalized in their lives, whether that be because of their racial identity, sexual or gender identity, or even their body size and the ways in which they and their voices are diminished and pushed to the margins in ways that are harmful to their self-worth and their experiences of just the normal transitions of life. These are definitely things that greatly change the trajectory, including intersecting with medical providers. And so my work has really been around training because of the impact that I see in the clients that I serve, that many, because of whether, again, because of the intersections of race, sexuality, and identity, and gender, as well as just the ways in which they show up in the world. They are sometimes traumatized and experience bias as they have to intersect and interact with providers, whether that be mental health, medical personnel and professionals. So I'm really excited to work with providers in that area. The reason that I also think that it's important for us to have consistent, honest, authentic conversations about bias is because we all have them. So this notion that implicit bias, that bias is understood, that it's something that as human beings that we somehow, somewhere have belief systems, we have automatic associations that are based in our worldview and our perspectives. And so that's the things that we know for sure as truth and fact. And then there are the things that we don't know. And there's so much that we don't know about the people around us. And so I think that it's important for us to, on this journey of creating equity, to be very clear about, being able to work through the biases that we have, because they are harming, people in various ways, and changing access to quality care. So yeah, I'll say more in a little bit.
Great, thank you. And let me thank all of the people that have joined us today, and maybe some of you who weren't able to, for some of your pre-submitted questions. We've guided some of the planned conversation around that, and we'll weave in other ones that you also put up during the conversation. So we'll peel back the layer a little bit on, we've talked a little bit in general on some of the risks and things and impacts that implicit bias can have on healthcare status, on risk for marginalized communities. And there was a question that came in more about some of the risk factors and even epigenetic changes that trauma can have, that the trauma of over-racialization or discrimination can have on different risk factors that people may have, particularly even in the area of substance abuse or dependence and mental health risk. And so how is it that we can draw that connection, and what have you seen as far as that connection in between having experienced that discrimination and the association with increased risk factors for mental health or physical health outcomes or conditions? I'll start with you, Harry.
Yeah, just so that I understand the question, it's about implicit bias around more, I guess, like substance use and the intersection between substance use and trauma. Is that what I'm hearing?
Yeah, and how it is that implicit bias and the discrimination associated with that can have effects on people's different risk factors for substance abuse, for mental health disorders. How are the two linked?
Okay. Yeah. Well, I think it's helpful to answer this first by talking about what the definition, what the current understanding around addiction and substance and problematic substance use is. Right? Our current understanding is that in a very broad reductionist way, problematic substance use is whenever coping mechanisms go awry, right? So someone might turn to a substance because it helps to alleviate like a momentary pain, or rather more like trauma, which isn't momentary, of course, and then just keeps at it because the brain habituates and it becomes, it starts to attach itself to thinking that this substance or perhaps even behavior is necessary for survival or trying to stay away from pain, right? And so when we're talking about implicit bias and how I'm going to answer this question is, for a lot of marginalized communities in the United States, particularly, there's a lot of trauma that happens to them because we live in a very white-centered society. And so those of us within the BIPOC and other marginalized communities, we're often traumatized from the moment of conception, based on a lot of the research that I've seen. Whether that's intergenerational trauma or even just being socialized in a school setting where we may not have the explicit language for it, but we get exposed to things like privilege, classism, and racism. I know for me, that was something growing up that I endured, being one of a handful of Asian students in a predominantly white, wealthy suburb in the Bay Area. I would bring, my mom would pack me a very traditional Korean lunch, and I'd bring it to school. And of course, for those of us who had exposure to things like kimchi, sometimes Korean food smells a little bit funky, right? It does not look like a traditional peanut butter jelly sandwich, right? And so I would have kids making fun of that. And I remember having these epic battles with my mom about just like pleading with her about like, hey, like I want a more white-centric lunch option because I'm embarrassed of my culture. I'm embarrassed about the fact that I'm bringing this to school and it's setting me up as a target for bullying. And in fact, that was actually in kind of a really extreme example, exactly what had happened was I was bullied because of my culture. Now, you take all of those factors and you as a BIPOC and marginalized person, you take all those factors over a lifespan and you have a very difficult life experience. Of course, you're going to, without therapy or without really good coping skills, you may fall victim to things like problematic substance use or even problematic addictive behaviors. There's a lot of research actually within Native populations that show that one of the reasons why we might see a higher rate of problematic substance use on reservations or within Native American populations, both urban and reservation Native Americans, is in a large part due to the fact that they are so highly marginalized and they carry on this legacy of trauma. And whether or not these individuals may be aware that that is the reason why they're much more inclined or much more at risk rather to fall into these behaviors, it is a big risk factor for the Native American population. And I would say that we can translate that research over to BIPOC and other marginalized communities.
No, I think it's really great that you've brought up some specific examples with that too. And just to tie into, how would we sort of know some of that like past trauma, past issues that now show up and will manifest even in our provider-patient relationships or with our clients, right? And how is it that you would even address that? And it's a tough thing when in the country overall, there's this push to not know even some of that history and where that might come from, right? I mean, even just recently, like Canada exposed us, sort of these mass graves that had Native American children in them, not to trigger upset anyone from such a, description of an image, but that is very upsetting. And obviously that's connected to quite a bit of trauma for the people whose bodies were then found, right? And yet, and still, I think most Canadians and most Americans couldn't tell you the history behind some of that, but it's very real for some communities and it's passed down. And then it shows up in our everyday interactions with them, in your wanting to build provider-patient relationships with them, right? And have that trust and understanding. But it's really tough, when there's an overall pushback on trying to understand their history, their trauma that leads them to be the person that they are today. So I think it's really, important that you bring up some of those things and how the history of trauma is often connected to how people show up in the healthcare world and in the world, right? And the needs that they have, with that. Dr. Smith, I'm going to pass it to you as well to speak about, what you've seen as far as connections between past history, risk for risky behaviors and behaviors that are not helpful for a person to have, and how that sort of ties in with how implicit bias is built into our system as well.
Sure. So, my research is in the intergenerational transmission of ethnic and gender identity, especially for Black women. And so, within that work, there was so much of a connection around epigenetics and some of the generational trauma that Black women are experiencing, and the ways in which, they then, have to socialize their children and grandchildren around, having a sense of pride, but then also at the same time, preparing them for a world where they are not always going to be accepted or going to have to consistently show themselves approved and go the extra mile to do extra work to show value, and not always the value, in going that extra mile, just being able to just be treated and as someone who matters and someone who, even has a voice, right? You have to kind of go the extra mile. So there's so much already there around the intergenerational transmission of trauma, and how things like racial trauma complicate that, and experiences that are triggered. So, when we collectively see, when communities collectively see or experience trauma. So for Black communities, it can be around seeing another police shooting or killing, and that collective, kind of triggering that occurs. These are the things that we experience, whether we are together in the same room or of the same generation or not. There is also something called post-traumatic slave syndrome that also speaks to this intergenerational transmission of trauma. And so, the impact of criminalization within Black communities, for example, and the breakdown of Black families in the system that continues to allow this to breathe and thrive. So racism actually has a direct connection to things like mental and emotional wellness, to experiences of depression, anxiety, suicidality. And these are things that, we kind of, if we take them individually and we don't look at the implications of racial trauma, then, we find ourselves asking the questions of what's different about these communities. Well, what's different about especially communities of color in the United States is that there is an extensive history of trauma, and of decentering and of marginalization. And these things absolutely have an impact on how we develop and how we grow and how we experience just everyday, life, right? And so the statistics are there. But then also, you know, anecdotally, we have so many different experiences. You know, thinking about Harry's share about, you know, his lived experience. You know, as such a young child, as a child of color, the experience is not only that your family has to go through, but that you have to go through on your own. The bullying, you know, at 5, being called the N-word and then punched in the stomach, and having no idea even what the N-word even meant, and having to go and not only ask my mom, but to also, you know, experience the pain that she felt because this was my experience. And so the responsibility that young children have, that you know, this is something that is absolutely passed down because it is in the very fabric of who we are and how we experience the world. So this is not just about race. This is marginalized communities. This is the effect of marginalization. This is the effect of minoritizing communities and doing so in a way that is systemic. So when we go to the doctor, when we go to school, when we, you know, attend, you know, when we go somewhere that we haven't been, when we were just talking before the panel, when we drive around the country, there are added you know, things to consider. There are added considerations, communities that people who are disabled, people who are experiencing class discrimination. These are things that absolutely create trauma and an everyday trigger of that trauma based in the, you know, the experiences that we have.
No, well said. And I think, you know, key things about what both of you have touched on is, you know, the repetition of the trauma as well. So, you know, it starts with sort of not acknowledgement, not like having the trauma, then sort of not acknowledging the trauma, then, you know, people saying triggering things, you know, unconsciously, consciously, right? That also then lead to like a repetitive experience of that trauma. And I think, you know, by the time you get to sort of, you know, if those of you who treat adults and you have a person who's gone through a number of those things and just had it over and over, you can get to sort of a numbness, something that's calloused over, right? And it's difficult sometimes to reach them. And I think by, you know, the purpose of me sort of saying those statements before is to say, like, here's the pathway to that either perceived or real numbness on your side when you're trying to reach someone, or callousness, and then to go back down that path to understand why that might be and what you could do to sort of loosen some of that up. So acknowledgement, right? Letting a person define their own experience, believing them when they say that they've been traumatized. All of those things are helpful. And that works for any paradigm. It's in, you know, implicit bias here, where we're talking sort of either about marginalized communities in various ways. But I mean, people say that for victims of trauma at all times. It's like, let them speak it, believe them, don't challenge them on it, right? Don't make them wrong for having experienced it, for expressing it, right? For being upset because of it, like all of those things. And so, you know, when you think about the provider-patient relationship with that, those are all things that just we as humans and providers can provide to somebody else to try and build that relationship. But understanding that pathway through, you know, really helps you get there a little bit faster with them, or understand someone. You know, a question came in that was a little bit piggybacking on some of this. And you know, the question of how discriminatory language and behaviors with providers or in healthcare systems really lead to marginalized people not getting care and not being able to make those connections and then get connections to the services and have their needs met with the existing systems that there are. So I wonder if y'all could speak to what are those sort of discriminatory language patterns, barriers that, you know, maybe more specifically that providers can look to, that they may be consciously or unconsciously doing that really lead to marginalized people not wanting to seek care, not continuing a relationship, not really opening up in a way that, you know, with intimacy that allows for there to be a therapeutic relationship to happen, so that, you know, some of the people on the call who are really trying to seek those things could take something away and really help themselves with that as well. Harry, I'll start with you.
Yeah, I love this question. This is a great question, because I was thinking about it kind of as we were talking. In terms of language, I think it's really important for providers to abandon the idea that they are the expert in the room. I think this is something that medical schools and even perhaps even the medical community sometimes pushes, is this idea that if you have an MD or an advanced degree in medicine, that you're somehow the expert of the client's medical experience, whatever that may be. And really taking the time to really more of a curiosity, a curious approach to how is my patient experiencing whatever health or whatever primary concern that they're coming to see the provider with, right? A great example that I often hear a lot of within my practice are my clients who struggle with eating disorders, or even who struggle with weight. I work with a lot of gay men where there is a hyper focus on physical appearance and what they look like. And so there are a lot of, and so I get a lot of stories, myself included, from doctors who will look at a patient's weight and look at a BMI that gets automatically created and then make value judgments about it, right? Personal experience for me, I'm a 6'2" man, and I work out pretty consistently. And so my weight usually is above 200. For the BMI, oftentimes I get placed in a 25 to 26, which is overweight. And my most recent physical last year, I was really upset by my doctor because he messaged me after the physical and said, hey, by the way, your BMI is high. How about we work on exercising? And I was like, I told you when we were talking that I work out at least 4 to 5 days a week, that I'm active. I may have a sedentary type job, but I balance it out with activity, with as much activity as I can. And it really made me very angry with my primary care doctor, because I had sought him out because he was supposed to be a gay man who I thought would be different, and I appreciated the questions he asked for sure. He had his good points. And so, a great thing that he did was he asked about he asked about anal pap smears and kind of making sure that if I was a bottom or if I was a top. He asked those questions. He knew the language to ask, which made me feel better about the visit. But then afterwards, it kind of felt like he backtracked because all he saw were numbers, and he made an assumption based on what he saw. And so I think that's something that really providers can really be aware of, is that patients are really susceptible to some sensitive topics like race or especially weight concerns. Really taking the time to understand that there are factors that the numbers only get you so far, and that really you should be taking the time to listen and to hear out your patients and figuring out what is their experience. Because just because a client, or rather a patient, might be may look or come out at a certain weight, doesn't necessarily mean that they're not doing everything possible to maintain a healthy regimen and making sure that they're doing everything they can for a healthy lifestyle. And similarly for gay men, taking the time to really educate yourself, or even asking the patient, if there are any other concerns, or if there's anything specifically that they want to bring up, or even just being educated in just basic concepts of the gay lifestyle. I mean, as a health provider myself, I take my health very seriously. So I go to my annual physicals every year. Up until recently, up until I had this gay doctor, not one of my straight doctors ever asked me about my sexual health, or walked me through sexual risk factors. And this is not just my own experience. I also have gay clients who do this as well. I just had a client actually recently where he's been struggling with issues around his prostate, and he's got some really great awareness about his urogenitals region. And his doctors have just been ignoring and kind of dismissing his symptoms because they're just thinking that it's psychosomatic. And in this most recent session, my client revealed that he had a chronic STI. And I had to stop session. I said, do your physical providers, do your doctors know about this? Because if you have a chronic STI, that can definitely cause the issues that you're having. And my client literally looked at me and was like, I never put that together. No one ever asked me about this sexual history. And you could just see the light bulb and just the level of relief that he finally had an answer, that this wasn't, and of course he's going to get it confirmed by a doctor, of course, but this is the problem I run into a lot, not only on a personal level, but also as a clinician hearing from my clients, is that doctors are not taking the time to take a full, complete history of, and not just a medical history, but also understanding the cultural factors around their patients. And it really causes a lot of the pain. In my opinion, it furthers a lot of the implicit bias that happens within the structure. Now, I know that that's also very reductionist. I understand that there are structural concerns for a lot of doctors, namely insurance companies, as well as the provider shortage that we're having in this country. And so all these factors come in to really create a very difficult situation for providers. And I understand that, but I also think that something that providers can do a little bit more of is to ask the questions that that may be very pertinent to their clients' cultural and cultural backgrounds.
Mm-hmm. Like an interesting theme I always hear is sort of this avoidance cycle, right? So I think even what you were saying, Dr. Smith, around the conversation we had before the panel started around, like, if we were to like drive through certain places in the country, right, that people that might look more like us or have an experience like us or be part of a marginalized community in any way, because of either gender identity, race, ethnicity, LGBTQ status, any of that, we consider things that other people maybe don't consider for our own personal safety, for our own experience, our own mental health, right? Where we literally would not go to certain places in the country at all. And so if we, so the idea of taking a trip to all of the national parks and a road trip, I've heard of people describe these like, here are the things you should do with your family. And I'm like, do you know how many families that would be like, provide a lot of angst for? Because the question is, where could you go? Where could you stay? Where you'd, maybe be treated with dignity or not be discriminated against, those kinds of things. And so what you do is you avoid that. Right. And so that's just one example of how you might manifest like avoiding something pleasurable or wonderful in your life or something that's helpful. Right. So you might avoid going to the healthcare system because you just don't feel like you're going to be heard. What's the point of booking a visit, sitting and waiting for someone to see you, and then they don't cover things that are helpful for you? And at the end, you maybe feel like they've judged you in some way that you didn't walk in with. Right. And so people just avoid that uncomfortable situation. But in that means that they're not getting care, that they're supposed to be. And on the flip side, the providers avoid the conversations that they're maybe not skilled at having, or they're uncomfortable with having, right? Or they've already made a judgment about someone, and so they don't even ask the question. I've heard even of like, so your experience here, I've heard of, like older women, especially, like also never being asked about their sexual health. It's like once a woman has like, gone through her reproductive phase and had children or not, and like after that, apparently she's not a sexual being anymore. So there's no questions around, how to help her have a productive sexual life or after that, or how she feels about it, or like those questions just don't even get asked, right? And so it's this like avoidance sort of paradigm that we go into on both sides. And so, I think the call to action is for us skilled providers who have the greatest intentions of really trying to help our patients, of breaking that avoidance cycle on both sides, right? And having maybe the uncomfortable conversation, or breaking the silence with just an open-ended question on what else somebody would like to speak about, and just bringing up some general topics to let them know there's a space to speak about it, even if you're not the most skilled in doing it, right? Certainly in our training, we always do see one, do one, teach one, right? So you've got to get in there and practice. And I think patients are a lot more forgiving sometimes than you think if you bumble through, if you have really good intentions and you admit that you're not the best at it, but you'd love to help them, right? So, there's, stuff on both sides to sort of work with, making sure that relationship does work. Dr. Smith, can you speak a little bit more about some discriminatory language and behaviors that really lead people to not getting care, and some of, like the avoidant behavior, and how we might get past that? I think I'm going to follow up this question some with, people have asked a lot about how is it that we can train people better in these areas, right? And how can we get to a point where we are, breaking some of that cycle and not just basing all of our knowledge on the weird population where everything was researched and then, all of the sort of protocols were built off of.
Absolutely. I think that one thing to add to what you, Dr. Malloy, and Harry, you've already said, is that, yes, we can, definitely share and very, like, we have these examples ready. And the challenge with it is that as a person at all these intersecting identities that are both privileged and subjugated in some ways, that I don't always know what the reason is that that I have the experience that I do with my healthcare providers. I just know that I have them. And so my answer is kind of twofold. One, I think that as we listen more, people are absolutely sharing their experiences. If we look at the research around and the conversations around Black maternal health in this country, there's been so much information that we could easily access if by just doing like a Google search or connecting with people who we know work in that area. Morehouse has a really great focus on, maternal wellness. And I think that that it is our job as providers to go and find this information. And a lot of this information is both empirically supported as well as anecdotal. And so we can go and find this information. We also need to be asking questions of people who experience, the type of healthcare that we provide. And so we want to be asking questions around experiences in the past with healthcare providers, especially if this is the first time that you have seen someone. As a therapist, I am asking people's experiences in therapy at every consultation. The reason is that I want to know if there is an additional area of trauma that has been caused by another mental health provider, maybe even with my same license. I need to know how and where this experience or who I am triggers them in some way. The second part of my answer is that it is on us as providers to know the things that we say and the things that we do that come from bias. We're really the only ones that can say that, okay, I have a racial bias, or my bias is around sexuality. And so we have to kind of go on that journey to find those things. I think that collectively, and as a culture, we don't talk about, sexuality enough. We also don't talk about the gender spectrum enough. We also don't know how to talk about race. And so these are three areas, but there's so many. We don't ever even mention class, but there are very, very significant disparities around just class, right? And so the information that we have, especially when we're in financially underserved communities, it's kind of our responsibility to know when we're, writing a prescription, for those of you that write prescriptions, that may be something that's not accessible to a community. Just recently, I had no idea of the price of asthma medicine that comes in an inhaler versus in a liquid. And as a family navigating chronic illness in my 2-year-old, there is so little information that I can get from my providers, even though I have the privilege to be able to like go and access information. I still have holes. And so to be able to ask those questions and to say, you know, maybe I don't know the lived experiences of this person, or maybe I'm assuming that they can't afford something. And so therefore, I'm not necessarily having this conversation. I'm basing what I'm doing, my behavior, off of an assumption. The other thing that we have to know is that there are times where it's okay to stereotype a person, it's been made okay to stereotype a person and to overgeneralize. And we have to be the ones to deconstruct those stereotypes and to say like stereotypes are harmful. And so, you know, we have to like kind of be that first line of defense for the people that we're serving. So if we know that we're not asking questions about race because we're uncomfortable about race, or we're not asking questions about sexuality because maybe we haven't learned, you know, some of the additions to the acronyms around, you know, sexuality and gender. If we're working with, you know, Indigenous populations and we haven't learned about what it means to be Two-Spirit, these are things that we absolutely are responsible for. And so that starts with training. That starts with engaging yourselves in different ways in the training. And then also, Dr. Molly, like you said, like, you know, trying it out, you know, walking in and trying out, you know, hi, I'm Dr. Smith. My pronouns are she and her. What are yours? Oh, I see this name up here. Is this your preferred name? Oh, we don't have a spot for your preferred name. I'm just going to write it in, you know, just being able to have conversations, just like, you know, I'm terrible at small talk, but, you know, trying it out and saying like, you know, if I misgendered you, I'm so sorry. You know, identifying the fact that there's a problem that you acknowledge and apologizing for it. These are the nuances of connection, communication, and relationships that we all have learned or want to brush up on, or whatever the case may be, and to kind of take responsibility for the ways that our language may be peppered with assumptions that, you know, are hard for a person who has less power in the room to challenge. And so we have to acknowledge that.
No, I certainly think that not oversimplification of a person, and then asking them, you know, how is it that you would like to be identified or seen in the room, or what would you like to speak about, and what would you like this to be, right? Allowing that room up front a lot, and the practicing of cultural humility, right? Like, you know, I'm coming from all of my intersections and what I understand and what I know, and there's a lot that I don't. You know, and so we're here to sort of learn and grow and form a plan of care for you together that works for you. You know, I'm gonna try with what I know to get there, and some of that will work, and some of it won't, and some of it will be incorrect, or it might say, you'd say, I prefer something else. Feel free to say those things to me, right? Kind of thing. Like, just leave the room open so it's an actual conversation and discussion, right? And you know, just to, you know, say something about what you said, Harry, earlier, where you were saying, you know, abandon being the expert in the room. You know, as a trained physician, that is tough, right? So, and often, sometimes what I'll say is, you know, there are two experts in the room, right? So I will say, you know, I have my expertise in my areas, and there's some gaps there. And I often will treat, and I'll also tell the patient, I believe you're an expert in your areas, like namely your body, your life experience. Like, you know, if I prescribe a medicine and then I ask you how'd it go, your answer is going to be completely different than the patient that was just before you that I prescribed the same medication for, right? So you're an expert on how'd that go for you? How does that work in your life? Can we do this moving forward? And I need to hear that expertise, because that absolutely directly and specifically alters or you know, affects the plan of care that we're going forward with together, right? So if I don't have that information, it's like I don't have all the data, right? Like, you know, I learned a number of times that some of my middle-aged men just weren't taking the blood pressure medication because it was affecting them, and they were having erectile dysfunction, and they weren't telling me. And that's why they weren't taking it. Now, high blood pressure is a problem. And I'm sitting there like upping medication, doing these things. And it really is just like, we're not having the conversation on what's going on with you. And you're the expert in your life on, can you make this work? And I'm not hearing that. And that's just like a critical piece of data, right? It's like how, like you're not taking the medicine for this key reason, right, in your life. So things like that. And just leaving the room and space open for people to be the expert on themselves and add that expertise in the conversation as well. So I think we tried to talk a little bit more about training and what people can do. There's a number of questions coming through on really motivated people who want to know about some resources or how it is that they can affect when they are supervising other people or they're in charge of training other, students, residents coming up on some of these topics and what sort of tools they can use and resources and how they can be positive effect and change. And so I want to throw that out in a more specific way. And I'll start with you, Harry, around even things that you've done in your own practice, because I know that you do supervise a lot of people, and how it is that you approach things, what sort of are tools and approaches that you use that are effective.
Yeah, absolutely. Just a quick thing that I picked up on, Dr. Smith. The trans community is moving away from using the word preferred name just because it's being seen as transphobic because it's not a preference, it's who they are. So the language that so this kind of leads into the question, the language that I use is what is your legal name and what is your name? Because some trans folks have not gone through that process of changing their legal name, and so what they may have on their legal documents may look differently, in terms of like insurance, other things may look differently from their actual name. And so just kind of, that was something that I made that mistake once years ago in front of a trans client, or a trans client, excuse me, and they really quickly were like, it's not a preference, it is my name. And my legal name is X, right? So
thank you so much, Harry. I appreciate that.
But this is a great example of what I encourage my supervisees to do, is to let their clients teach them. I have learned so much about the trans life experience from just sitting and listening to my trans clients. Dr. Malloy, what you said about cultural humility, and I really like what you said about there are two experts in the room. And I think that is something that is so important. That is something that I do with my supervisees all the time, is I tell them, you may have some subject expert matter, or you may have some expert subject matter in applying therapy and in delivering therapy, but this client's unique story, cultural factors, trauma history, how they've created their world perspective, you have no idea what that is. So the best concrete advice I could give here is ask, don't assume. That is the central theme to my therapy, to things that I teach my supervisees, is always ask, do not assume. If you have a curiosity, say it. If it comes off wrong, or if it comes off in a way that might rub the client the wrong way, practice humility and say, I am so sorry. I did not mean to hurt you in this way. Please educate me. Please bring me up to speed about what is happening. And I will tell you, that was exactly like you said, Dr. Malloy, it was one of the hardest things. One of the defining moments of my practice, and continues to define my practice in working with the communities that I work with and how I educate my supervisees, is I once had a very tough session with a trans client, and we had gotten onto the topic of attraction. And this client wanted to ask me about my experiences of attraction towards the trans community. And I said something along the lines of, I have never found myself to be attracted to a trans person. And the client looked at me dead on and said, how would you have known if that person was trans? And this client, we had maybe 10 minutes before session ended, and they started packing up, and they were like, this was definitely the wrong you're definitely the wrong therapist for me. I don't want to be here anymore. I'm going to leave. And I said, you're free to do so. I hope you come back. I'm so sorry. I did not realize how transphobic those words were. I invite you to educate me, give me material. I will do my research between our sessions to better inform myself, better inform the other clinicians that I have. But it was a tough session to really sit there and just kind of sweat with the client, because I don't intend to cause harm, and very clearly for this client, they were really upset about it. And it followed some really amazing but very tough questions and tough discussions with this client about, how to not perpetuate these transphobic issues, and to really be more open and honest with all of my clients about the things that I wasn't aware of. No one in grad school, none of my professors in grad school ever taught me about the trans life experience. And so I had to learn on the fly with my clients, and I still do.
And so many of us are in that boat still, right? And it's just, hopefully this panel helps encourage everyone to stay with it and stay in the fight in a way, and to get better. You can get better, right? You can learn. Really appreciate, thank you so much, Harry, for your vulnerability there and sharing a real life example that people can, relate to and hear and know that they've been in a situation where they've had to sweat with a patient, right? And that's part of the job, right? I mean, I think we all avoid it a bit, just like, sometimes I avoid the gym because I don't want to sweat there either. But I think, we avoid uncomfortable situations, but that's part of it. And going through to the other side, gets you somewhere better, right? And gets you more able to do what it is you've committed your life to do in helping people, right? And it's not that you can only help people in this one bucket, but you can be a therapist for anyone. You can, really relate to and create that space for anyone. So, it's worth the battle. So hopefully we're giving some tools out there for that. And I'll pass it to you, Dr. Smith, to speak a little bit about, like, when you are teaching others, even when you're thinking about like designing continuing education, what's the approach and the perspective that you're taking on that and what you're trying to achieve, and like what can other people pick up from where they're at to get started and to make sure they're actually going down that path versus just sort of maintaining the status quo?
Yeah, that's such a great question. And I look forward to my answer since I'm answering in front of my boss. But I really do appreciate being able to like ask yourselves just like regular questions, right? When you're checking your bias, being able to say like, who am I usually around? From my family to my social groups to social media, who am I exposed to? And then what types of who are these people? What are their race? What are their, all of the different types of, identities and who they are, right? I'm also learning to move away from, even though I've said it several times, identity, because, it's who a person is, right? So what's your gender, not your gender identity, right? And so these are ways in which the only reason why I've learned that is because I've changed or I've expanded and had more diversity in the people and the ideologies that I expose myself to. And so there's still so much work for that, and it's really like a lifelong thing. But if you're able to just look around you and to conceptualize, who are you usually engaged with on a daily basis when you go to the store, when you do your work, the communities that you're in, when you're, coming into, work or like a meeting or something like that, your family, who are you talking to on a regular basis? Who are they? And then what are some of the similar, not so similar, different ideologies, thought processes? What types of conversations do you have? And if there is something, as there are things going on in the world, who are you exposing yourself to? What belief systems that maybe even are different than your own are you exposing yourself to, so that you're able to get a bigger worldview? Even the term race, for example, does not translate globally. So then if you're having a conversation with someone about skin color who, you know, doesn't use the same term, then that means that I need to learn more kind of this global perspective around skin color and the experiences that go along with that. So by increasing our worldview and exposing ourselves to various cultural belief systems, then we are increasing our knowledge about society and also living in the value of diversity and being able to consistently hear different voices. We can also do like formal things. So, you know, there's a Harvard implicit bias test that, you know, has been tested and is, you know, something that is tried and true over various generations of, you know, people, especially like, you know, mental health providers who have been in graduate school, who have had some assignment associated with the Harvard implicit bias. I think that that's one of the tests that a lot of people use in training. I think also ongoing trainings around cultural humility, which is an anti-bias framework, and being able to transition from, you know, kind of like this book knowledge of cultural humility and culturally responsive practice to how does that look in person, and, you know, one-on-one, face-to-face. I think those things, that's the awkward part. We can, you know, read things and, you know, have our own understanding, but the awkward part is how then do we apply this? And we apply it by, you know, doing it scared and saying, I most likely am going to fail at this in some way, and I am going to be impacted by that. As mental health providers, we do a lot of, you know, as a therapist itself, for the therapist, I think that translates through many clinicians and providers. But what we learn is that who we are, not only who we are in terms of our social experiences and our social location, but also, you know, family of origin and, you know, what we do and all the various experiences that we have at those intersections. We learn that those things show up in the room as well. And they're showing up with their own areas of oppression as well as privilege. But then in the room, as we are, you know, let's say providers, there is an inherent power there. And so to acknowledge that and to flatten that tends to bring in some curiosity. It also tends to bring up, you know, some ways in which we can, just on a person-to-person basis, be able to say that we are here working on a common issue, and that is your health. And so how can I help that? Not necessarily lead it. How can what I am here to add to help you, how can that work within who you are, your, you know, what you do on a daily basis? It's so interesting, the amount of times that, you know, I have gone to a provider, mental health, you know, a medical provider, and have not been asked what I do. And so, you know, around issues of infertility, for example, so many doctors have said, well, you know, you got to decrease that stress. And I'm like, okay, but hey, I'm a therapist, and like what we do is pretty stressful. So how, you know, can you help me with a little bit more information? And I feel like if they knew this, if they asked, if they were curious around it, then we can work together on, okay, well, here's another way that you as the expert in the room could work around. I mean, because therapists and medical providers may have some similarities around schedule, right? So we may be able to work together on what are some things that, you know, you do. Or, you know, my clients ask me this all the time. I think that, you know, therapy sometimes has more space to for us to share. But I've also had medical providers who have, kind of like shared something with me that helped me feel a little bit more normalized and less minimized. And so I would say that, being able to expose ourselves is like to all different types of people and cultures and all of that is like the best learning experience. And to have conversations is as awkward as they might be and as emotional as they might be, right? Have conversations with people that think differently than you do, that have a different political belief system. What we're seeing is so much struggle with having conversations and just shutting others down because we don't know how to converse about difference. We don't know how to converse about the beauty of somebody thinking differently and how we can collectively look at something from different sides, or the power of disagreement, right? And as couples, sometimes, like in relationships, when we look at romantic relationships, sometimes a disagreement breeds something beautiful. Or at least, a great stress reliever. So we need to be open to those possibilities in our work and in our personal lives as well.
For sure. I mean, we're definitely seeing this overall shift. I mean, I think the paradigm of how most of us were trained and how, a lot of people say is that, actually establishing that power differential is a good thing for someone to, respect you as the expert and follow your recommendations. And I think, they're just changing times with and we've just seen it in the data, like that doesn't seem to be producing good results, right? Particularly with people who already walk in with always having to deal with power differentials or marginalization or discrimination, right? They're essentially just going to avoid you, or they're, going to nod in your room and then do what they want to do, right? Because they just don't feel like the recommendations are ring true for them or will do something for them, or it's coming from a source that has tried to understand them, right? And so those recommendations don't stick, right? Because they just really don't feel like it relates to them. So there's just a different paradigm that needs to be looked at, and it's okay to struggle with it initially. We're often all not trained in that way, but we're all just people, so it's learning a new skill, figuring out a new way to get through something uncomfortable that gives you a better result on the other side. So thank you for those tools. Like in the chat, actually, some people have been throwing out some of their own resources. So that's good. I mean, so if there are any particular podcasts, books, different things that you guys want to recommend as well, please, we'll give you a chance to say that. People have thrown out this book called White, W-H-I-T-E, White Awake, not Wide Awake. White Fragility has been put in there. There's been a University of Washington article. I know, we've already cited the Harvard implicit bias study and how there's actually tools in there. I think it's important as we're looking at it, certainly the background education, but then there's like, when you have influence in an organization and you want to sort of even assess where you're at, because I think a lot of times people don't even know that, right? I mean, I think you think because you have good intentions that you're in a good place, but that doesn't necessarily always translate, right? Harry very vulnerably gave us an example of, coming from the best of intentions and not realizing that like the result was just not at all what he intended, right? And so having to step back from that. So, good intentions certainly matters, but also actually trying to give some objective assessment or seeing how is this actually functioning and where am I at in the spectrum, as we're all trying to learn. So those tools that are in the Harvard implicit bias study, I think are good. And if there are any other ones that you guys think of that people can use to either individually or as an organization, look at how is our organization doing. So I want to throw out that question as well, because that came in some of the pre-submitted questions and ties in that what metrics can you look at with yourself as an individual or as an organization to say, are we doing well at this? Do we have signs of commitment to this? What can we track to say if we tried to get better at this, that we did get better at this? I think those are, up in the air. People don't necessarily know where to start with that. And they want to know, am I doing something that's working or useful, right? So Harry, I'll start with you with that. When you're looking at training people or you're looking at an organization, what are signs an organization's doing well here? And how can they track to see if they do any better?
Yeah, so this question may be a little bit out of my depth just because I don't work in a hospital setting. So I don't know in terms of like, I guess like within those types of systems, how to really work with it. But I think really like Dr. Smith was saying, like really adopting this very curious mindset. So, I already said, ask, don't assume is something I tell my clinicians to do. The other one that keeps coming up as we're talking about this is something that I tell both my clients and my supervisees, which is understand that there is a difference between impact and intent, right? Just because you intend to not be harmful does not mean that the impact is any less harmful, right? But taking the time to really help, as Dr. Smith is saying, also really just taking the time to understand and to do kind of couples therapy in a way, or relationship therapy in a way with your patients, to be able to kind of repair that process and admit that you're wrong, that and just kind of putting out there your perspective of saying, hey, I'm sorry, like I was not aware that this was happening. This is where I'm coming from. Other resources that I would probably, for the sake of this panel, that I would highly recommend are the two very classic books on the subject. The first one is Mountains Beyond Mountains. It's the book about Paul Farmer and his work within Haiti, and the other one is When the Spirit Catches You, We All Fall Down, or something like that. That's another. These two books tackle the topic of providers not understanding cultural differences. The book Mountains Beyond Mountains really tackles structural inequities between the within the Western Hemisphere of the United States' healthcare versus access to healthcare in Haiti, and what Paul Farmer tries to do in terms of kind of bridging the gap to provide Haitians with quality healthcare. The second one, When the Spirit Catches You, is all about cultural biases and how it impacts delivery of care, right? So that book talks a lot about Hmong refugees within Merced, and doctors trying to push their understanding of epilepsy to onto this community, but the community has their own interpretation of what this child is going through in terms of the epileptic seizures. And you find a social worker who's kind of thrown in the mix of trying to like balance out, like, no, this isn't a CPS case. They just don't understand what's going on, and they don't understand things like that. There's another one. Crazy Like Us is another interesting book. That book is all about the exportation of Western concepts of mental health onto other community, into the rest of the world. And so it talks about how especially the DSM-4, I think at that point, how that's been exported out to the world, and how it's not really jiving with the rest of the global community, because a lot of what is being written is, or how we're conceptualizing mental illness is not what we might see in other parts of the world, right? So depression for someone who is white may look very textbook, may look exactly like how it's written in the ICD and the DSM. But then you have a client who is of a minority background, depression will look differently. Depression looks differently across age spans, or across the lifespan, right? Children express depression much more externally, so they externalize a lot more. Teenagers just get really moody and they withdraw a lot more, for the most part. They also externalize too. I want to make sure that we know that. Men and women express depression differently. And so how I usually will interpret that for my clients is, what's the flavor of depression do you have, right? So that way it helps to kind of, yes, there are generalities to what depression can look like, but there are different flavorings of it, right? So for a gay client, they may be depressed because their depression is taking on the flavor of you're less than worthy because of your sexual orientation, or no one's going to love you because you're gay. And, that's the flavor of their depression, is it takes on this very shaming, self-worth, criticizing flavor, versus someone else who, let's say like a rich, privileged white man, the flavor of his depression may look similar, but it manifests differently. It might be more like, hey, if you don't meet, the productivity that you have to meet for your job, then you're worthless, right? Right. The concept, the general concept is worthlessness, but how they're being approached and how they're manifesting is different, right? And so taking the time to really kind of figure out what is the flavor of that depression or anxiety, but really, I guess more concretely, what I would encourage providers to do is slow down and really, yeah. I get that that's really hard to do. My primary care doctor, just to get a physical, I have to call in January so I can schedule him in August, right? And so I get that it's hard to slow things down, but where you can, doing your best to really just take the time to say, what is the story that you're bringing in here? And you can get a lot out of 20 minutes of just listening to a client or patient, and then really asking those follow-up questions, as we've been hinting at, of like, is there anything that I missed? Is there anything that you would like me to look at? Is there anything more that you haven't felt like I've been able to address, right? And technology is a great ally right here. Like I have access to my primary care doctor through a chat. Like I just go into the patient portal, and I ask a question, and like a nurse that works with him will get back to me within a couple of days about it. But those two books definitely are or three books rather, are ones that I would recommend, especially for this panel.
No, that's a lot of great resources, great specific ones, and then general approaches, right? And thoughts for an organization. Dr. Smith, what are your thoughts around this, on like how an individual can sort of look and assess themselves and also influence their organization to do that assessment to track progress?
Absolutely. We have to, power is like kind of in and through this whole conversation. And so, there's two things. One, we have to look and see if we have the power, the space, the privilege of being able to work on ourselves and to increase self-awareness. So Pamela Hayes, who is a counselor educator, created the addressing model. And so, if you spell out all those words, it kind of breaks down to age, disabilities that are developmental, disabilities that are acquired. It kind of goes through all of these different, social identities that would, allow us to have a little bit more self-awareness around what are some of the things that we need to be, clear of as we engage with the people that we serve, or when we go to work, or when we engage with leaders or teams that we lead, depending on the positions and roles that we have. So by first starting with that awareness and knowing how you do show up, because the perception, this is what we use, right? We use perceptions to look at people or to get data in some way that helps us better understand how to relate or what to do. And this is such an unconscious process that, by, as Harry said, kind of slowing it down. And Dr. Jennifer Eberhardt out of Stanford does research around bias, and what she calls causing friction are these moments that Harry was talking about, where we slow down, even if it's not like time-wise, right? Like if we don't have time in between sessions or in between seeing patients or whatever the case may be, it's slowing down even just our speech and saying, like, I'm going to be aware and conscious of the words that I'm using. That brings us so much data and information around how we show up. We also, as we can take responsibility and look at, various historical narratives, when we are, talking with someone, we can maybe even see some of those cultural, historical, and social implications, and they may not even actually have to say it. So, with COVID, for example, I have a Black provider, and one of the things that she said to me very, very early on was, she said that, because I don't know that it was like out in the world just yet, the numbers and the outcomes around, the bias that was occurring at the ER. And so the choices that were being made that had to be made in a split second on, who received what treatment and when and how quickly that environment makes it so that we have to make these decisions, and how very often what the outcomes show is that when we have to make quick decisions, that we're seeing that there are quick decisions being made for or against certain groups. So we see a huge disparity in the cases and the number of deaths in Indigenous, Black, Hispanic and Latinx, as well as Asian and Pacific Islander communities, and then and then another large community are immigrant communities. So we really do have this data, and so if we can use it and we can say, hey, please be very, very careful. Because what we know is, like when I'm talking to parents, right? What we know is that teens that are also exploring, their race and what that means to them, they are experiencing depression and anxiety at a higher rate, most likely because of the experiences that they have at school. There's suicidality that has skyrocketed in teenage and young adult, later teens and young adult populations. And so what outcomes tell us, what the research, this empirical data is telling us, is that at the intersections of racially minoritized, sexually minoritized, and gender minoritized communities, that there are even higher rates of suicidality and depression, anxiety, things like that. And so we have to be exposed to those things. This is for ourselves. Now, when we make sense of what that means within the larger system of, our professional setting, the workforce, where we do our work, we have to acknowledge whether or not we have the power to make systemic change. If we do have the power to make systemic change, then our responsibility to learning how to make those changes, and how can we sometimes go out on a limb to use the power that we have, whether that be social power or power within the system, to actually, show up as, an ally or a disruptor. We have to disrupt this bias. We have to do things about it. We have to have conversations. We have to challenge ourselves to say, am I going to lose my job by having this conversation? There are plenty of people that would, but am I a person that wouldn't? Then it's on me to go and talk about this, and to go and see if there are any suggestions that that I can make, or volunteer to say, hey, let's have a conversation about this. Let's hear the voices that we don't usually hear. Maybe even decisions around representation and employment. If you're a person that has the power to have more diverse providers within, the setting that you're in, utilize that power to learn how to go about doing that. Because what we know is that there is and looking very close at the outcomes, because the data is there, but data are there. But being able to say that, if we have a group of people that are making decisions that all not only look the same, but also have very, very similar ways of being, then the outcome is going to be that people who look the same and have similar ways of being are going to have a better experience with our organization. And the reason for that is that there's just no representation of somebody else's experience. And so we have to, that's like a valuing of diversity. That's not just saying like, okay, we want it in numbers, but it's also doing the inclusion work to say, okay, who am I hearing? Who am I hearing from? And are people with the same level of power, do we have representation within the power of a system? Because it is the powerful of a system that will ultimately change that system. Those that are disenfranchised are going to continue to do the work because we have to survive. But then also we need to be working alongside people who have the power, whether that be socially or within a professional setting. So it's kind of like an added responsibility. If we're leaders and have power, we have a social responsibility to change the very systems that are flawed and broken.
Definitely. No, I hear you on that too. And I mean, I always go back to like, there's certainly, you know, there's different arguments to make. There's sort of the moral argument, and a lot of times with providers, that often does very much work because you've committed yourself to this line of work anyway. You know, but it's also just, it's not working for us, right? As a society, when we look at the numbers, the outcomes, what's going on, and these are impactable things, what we're doing currently is often not working for a growing amount of people in, you know, say like in America, right? So we need to do something different, right? We have the data that it's not working, so we've got to switch that up, right? I would never continue a clinical regimen with someone that wasn't working, that was obviously not working, that was possibly obviously harming them. I would change it up, right? So I would, you know, so I think it's in a different lane, but it's the same thing and the same responsibility attached to it, particularly for providers and those of us like us as well. We are running low on time. We always have great discussions. I will end with one other question that popped up, and I think this sort of goes in the spectrum we were talking about. So how do you work with yourself and on an individual level to help yourself be a better therapist, provider, human being, community member overall? Then how is it that you can maybe leverage your organization, look at where are you at, make recommendations on valuing diversity in tangible ways? And then, maybe there's something in between, right? Something for everybody to do. And so somebody asked about, how can you help a colleague recognize maybe their bias or be motivated to check their bias? And that's why I sort of opened with it's not working for us to have it, right? I think that's a declarative statement on like why you might want to change it, right? You're not being successful. But are there other things that you might say to your colleague to, in a minute or less, what might you say to a colleague to help motivate them to maybe start on this work that everyone else on this call is doing? Harry, I'll start with you.
What I would do is just say, hey, let's go grab coffee, or let's go grab, a meal or lunch, right? Science teaches us that when we share a meal with someone, that we're more likely to engage in vulnerable conversation, right? So I would say start with that, be like, hey, let's go grab something. And then just kind of lead into the conversation and be like, hey, I just want to check in with something that you might have said, using concrete examples of places where you might have seen a bias show up and saying, hey, I just want to touch base about this moment that you had. Can we just talk about that, right? Instead of, I think it's really just a good place to always start with the fact that all of us have biases. Having a bias doesn't mean that you're wrong. It's a natural human thing to do, right? Our brain is tasked to just categorize information, so we're going to always have categories. And so what the intention here is not to remove someone's bias, but rather to make them more aware of how that bias, again, intent versus impact, right? How that bias impacts, the people that they may have unintentionally hurt, right? And so really just, again, I guess the concrete here is take someone out for food and then talk about your biases, right? Don't just leave the conversation like an interrogation where you're talking about your, colleagues' biases. Be vulnerable as well and to say, hey, I share this bias and this is how I got over it, or this is how I'm mindful of how that works.
Great. That's a great place to start. Dr. Smith, you want to close us out with that?
Yes, I will also, I love that idea, Harry, but I will also speak for the introverts in the room, where yes, meals are great, but they also are very, they're a lot of work for some of us. So, I think conversations are like, great. There are so many different ways in which we can do that. I think, having a Zoom conversation, is also, we've learned, the way of being able to connect virtually. I also just love being able to see at least what people on social media allow for us to see. There are plenty of people who are taking on the responsibility of educating all of us around whether it be their experience or the experiences of people who are similar. I mean, even just in the chat, there are so many different communities, marginalized communities that we haven't, that are outside of our purview, the three of us. We can't possibly acknowledge all the different areas of marginalization, in an hour and a half. So those of you who already know some of the lived experiences that are marginalized, be open to sharing that in ways that are comfortable for you. And then also let's go, collectively use all of the resources that are literally at our fingertips to expose ourselves to just a lived experience that's different. Even looking at, people dancing, people, listening to music, cooking, we can watch, I don't like cooking, but I like to watch other people cook. And so, exposing myself to what some of the ways are that people might celebrate or, that are traditional. It absolutely enriches and enhances our lives. And so, let's think about that interpersonally as well. What can we learn about a person that will enrich us? And so it doesn't always have to be like doom and gloom. I'm a biased person, and so, I can't talk or share. It's saying that this is an experience, this is a human experience. And let's join together and figuring it out together.
Great ways to end. I just watched a video about Holi that people are celebrating on Friday. It's traditionally Hindu, but all throughout India and that area of the world, often celebration of spring and birth and life. And there's always something new to learn and have fun with. So I think that's a great thing to end on. I'm going to pass it back to Meryl and Rachel. Thanks everyone for being here today.
Y'all are amazing. Every time I take copious notes, I learn so much. I enjoy the cadence and the dialogue. I hope everyone did. For participants who weighed in, thanks for sharing your experiences and asking questions. I think we've all learned today. Be curious, right? Learn, demonstrate cultural humility. Differences aren't bad. Differences are unique and engaging, and really they help us as we sort of look at the entire fabric and diversity, of our cultures. So Dr. Malloy, Dr. Carla, Harry, all of you, thank you so very much. Let's hold ourselves accountable, right? Let's stay together, keep in touch. Great resources were shared. And I think we need like a part 2 to this particular session. There is so much more and so much more diversity to embrace and to learn about. And to help influence the healthcare system to be a lot more equitable and accessible to everybody. So Rachel, anything to say to wrap us up?
So well said, Meryl. And thank you, panelists, so much. That was incredible. Such great information. I'm putting the type form in here one more time. This is the CE survey. It'll automatically maybe show up in your browser as soon as we end up here. And it will come in the follow-up email as well. I'm queuing it up, and all the resources that were shared, I have them. I am going to take a quick picture if all the panelists want to smile. Perfect. Got it. Thank you everyone for being with us today. And
thank you, Kent and Sharon also. Thank you so much. Sorry for interrupting,
Kent
Rachel.
and Sharon, for sure. Yeah. All right. Bye, everybody.
All right, thank you.
Thanks everyone. Bye.